This meeting is being recorded.
So good evening all. I'm Shuman on behalf of Shield Healthcare. Welcome you all in today's session on sperm in -196 degrees centigrade. Is it as simple as it sounds? In association with ejaculating, as we all know, that International Human Embryology Research Committee Academy, along with the Shield.
Technical thing. The signal is very low here.
So it's our events.
Hello.
Hello. I think there is problem with.
It's our immense pleasure to introduce our coordinators today, Dr. Nidhi Singh Madam, Yoshita Tanwar Madam, and Dr. Nancy Sharma Madam.
Hello.
Yeah. So Dr. Nidhi Singh Madam, Madam did her MBBS, MD, DNB, DC, MNA, MS, IMSA, and Madam is the Senior Clinical Embryologist at Panacea Hospital, Varanasi. She is the Assistant Professor at PIIRE, Panacea Institute of Interdisciplinary Research and Educational Academy, Varanasi. And she has a teaching experience of more than 16 years and multiple national and international publications. And Madam is a team member of IHERA and a member of various national and international societies like HRA, ACE, MNA, MS, IMSA, and many more. And in the field of interest, Madam has a keen interest in the andrology and cryobiology. So now it's time to introduce Ms. Yoshita Tanwar Madam. Madam is a senior embryologist and laboratory in charge with more than 8 years of experience in the field of embryology in New Life India Fertility Clinic Private Limited, and she is the certified in advanced skill set embryology training conducted by Mark Center of Excellence in Clinical Embryology, Kasturba Medical College, Manipal. She is the ASRM certified clinical embryologist, a member of ACE India and ASRM Society, and Madam is the team member of International Human Embryology Research Committee, that is IHERA. And now it's time to introduce Nancy Sharma Madam. Madam is the Chief Embryologist and Lab Manager, Department of Reproductive Medicine, IKDRC, ITS Hospital, the Civil Campus, Ahmedabad, Gujarat. She is also a certified embryologist and embryo and biopsy training workshop. She did from embryology and PGD Academy UCL, embryology certification course from Indian Fertility Society. She has experience of more than 8 years in the field of ART, and Madam presented many research papers in many national and international journals as a presenting author, and she is a PhD scholar and postgraduate in molecular biology and biochemistry from Guru Nanak Dev University, and Madam is the team member of IHERA involved in the Gamete Alert. And apart from that, Madam is the member of prestigious many national and international societies like ASM, ACE, and IHERA. So with this short introduction, I request Nancy ma'am to take over the session for further proceedings. So thank you very much.
Thank you, Mr. Suman. Can we have the series, please? Mr. Suman, can we have the CVs, please?
Yes, madam. CV is already there.
No, I cannot see it. Is it visible to everyone else?
Yeah, we can see it.
It's visible?
Yeah,
yes,
yeah.
yes.
I'll read it from my phone and reconnect after that. So today I want to introduce to our conveners. First, we have Dr. Ved Prakash. Sir is Laboratory Director of South Infertility Center and in IVF in Delhi, NCR. Sir is PhD and is the founder of Indian International Human Embryology Research Academy. He's past president of ACE and member of Virtual Education Committee, Society for Study of Reproduction, SSR, and faculty and fellowship. He did his faculty and his fellowship in ART from MED University. He's visiting faculty, MSc in ART. Mysore University. He did 8 chapter contributions in textbook and published papers and
Is being recorded.
In vitro fertilization, now I can see it. In vitro fertilization of two blastocyst formation. Then we have our Dr. Sanjay Shukla. Sir is Laboratory Director of Betty Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. Sir is currently the president of ACE, and he did his PhD in life sciences, worked on in early days in early diagnosis of typhoid fever, and working in the field of human reproduction since 1998. Can we have the next CV, please? In Dr. Charudat Joshi, sir is postgraduate in life sciences. He did his special trainings in IVF ICSI from Belgium and embryo freezing from KK Women Hospital, Singapore. Sir is past president of ACE and past vice president of ACE. He is also the medical director of Genes India ART Bank. So for starting the first session of the evening, we have a very wonderful topic, which is effect of cryopreservation on sperm. For moderating this session, we have Dr. Charudat Joshi, and as a speaker, we are having Dr. Chandan. So Charu sir.
Yeah. Hello. Yeah.
Can I have Charu sir CV, please? Yes. So Charu sir, as I already told, he is PhD, and sir did his post-graduation in life sciences and his special training of ICSI and IVF from Belgium, and embryo freezing from KK Hospital, Singapore. He done his special trainings in laser hatching from Belgium also, and he is postdoctorate in life science. He's executive committee member of MP ISAR chapter and executive committee member of MP IFS chapter also. He was past president of ACE and past vice president of ACE and medical director of Genes and India ART Bank. Now over to Charu sir for the introduction of speakers.
Thank you, Nancy, for such nice introduction. And without wasting further time, I would like to introduce my dear friend, Dr. Chandan. He is presently scientific director for Akshay Fertility Center and IKEA Embryology Training Center, visiting consultant at Kangaroo Care Women Hospital, Masoom Fertility, Aishwarya Fertility, Fetal Medicine Center, Mumbai, Manohari Fertility, etc. as a consultant embryologist and lab director. He has 13 years of experience in the field of embryology and visiting different hospitals in and around India. He has trained at various places, particularly in Crest University, Singapore, in National University Hospital. He is an MCOL certified registered embryologist by the American College of Embryology. And he is a director of Lanka Embryology Training Institute, Colombo, trained by Hamilton Thorne for embryo biopsy in Bangkok, certified for embryo biopsy by Anderson Genetic Lab for excellence in biopsy technique. He has many awards and certifications to his credit. So over to you, Chandan, for listening a nice and elaborate talk on the topic. Chandan? Hello? Hello? Is Dr. Chandan there? Hello?
Sir, is my voice is audible?
Yes, now you are audible. You are audible.
Sir, your voice is not audible. Actually, you have logged in from two devices. So, sir, simultaneously two devices will make it echoing.
You are not audible, Chandu.
Sir, you are not audible, sir. It's not audible, sir.
Hello, hello.
I think I have some technical issues.
Chandan, we can hear you now.
Yeah, fine. Yeah. I'm just logging from my mobile. I'm just trying to open the document. Just 1 minute. I have logged in from my mobile, but I'm not able to open my presentation. Or I request the second speaker to begin with so that I can finish off this technical error and log it for the second session.
Yes, we can
Okay,
start.
okay.
And do one thing,
Yeah.
Chandan. You please share
Yeah.
that presentation to me or maybe Sanket, someone else. So we will
I'll share the PPT now. Yeah.
Yeah. So we will do that, and in the meantime, RCA can take over, na?
Okay.
MC,
Okay.
we
Fine.
can start with
Yeah.
RCA.
Okay, okay, okay.
289.
So due to some technical errors, we are shifting our topics. We are taking first the lecture, that is media used in sperm freezing. For that lecture, I would like to introduce our moderator, Dr. Sanket Dhumal. Sir is MSc, MCE, ECE, EMPH, PhD, and he's working as a senior clinical embryologist in Keshma IVF Fertility and Reproductive Medicine Center in Mangalore. He is MSc in genetics and MSc in clinical embryology from University of Mysore. He's a consultant embryologist in multiple IVF centers. He's ASHRAE certified clinical embryologist, executive committee member of ACE, and scientific committee member of IHERA. He is also an editorial board member of journal JBRA, and he's also taking care of ACE newsletter and IHERA newsletter. He also work as a reviewer for journals like JBRA Reproduction, JRHM, and OGS. He's principal investigators of several projects at Keshma Medical College. He's also member of ACE, ISAR, ASHRAE, and IFS. Regular faculty in more than 50 various conferences, national and international both, and his area of interest are male infertility and cryobiology. So I would like to call Sanket sir for the introduction of speaker.
Yeah, thank you so much, Nancy, for that kind introduction. So, I'll be introducing the next speaker, that is Arshia. So she is MCE and lab manager at Nova. She has done a master's from Monash and in the year 2019, and she's currently the lab manager at Nova Jalandhar. And during her MSc, she has interned at various labs in and around Melbourne, and she holds a master's degree in molecular biology and human genetics from Manipal University. And while studying at Manipal, she did a 6-month project at TFR, Bangalore. And she has been active member of SIRT, Melbourne Association of Embryologists, and also recently the same was seen for the ACE 2022. She presented a poster on universal warming solution, which got her the first prize. So without much further delay, I would like to hand over the session to Arshia. So she will be talking on the media that is required for the sperm cryopreservation. Arshia, over to you.
Good evening, everyone. I'm just sharing my slides 1 second. Are my slides visible now?
Yes.
Good evening. So the topic for discussion today is sperm freezing media. So what is basically sperm cryopreservation? It is a procedure to preserve sperm cells, commonly called sperm banking. Cryopreservation is the freezing of cells or tissues to a sub-zero temperature, typically -196, which is the boiling point of liquid nitrogen. The first successful cryopreservation of spermatozoa was initiated over 50 years ago. For human sperm, the longest reported successful storage is 22 years. The freezing of sperm needs cryopreservation agents that minimize the damage to the cells during the freezing and the thawing process. How it all began: over 8 decades ago, in 1938, Lewitt and Hodapp performed the first vitrification of frog sperm in liquid air. Polge et al. From London claimed that a revival of spermatozoa that successfully froze sperm samples from various species with glycerol. The first attempt using vitrified sperm from human live birth was reported in 1953 by 2 researchers from State University of Iowa using sperm frozen on dry ice, and soon after the publication, normal live birth was declared. About 1 decade later, the same group tried freezing with liquid nitrogen and succeeded. Live births from the frozen sperm after 4 decades storage in liquid nitrogen had also been reported. The first successful cryopreservation of human spermatozoa that achieved pregnancies and live birth was reported by Sherman and Bunge in 1953, interestingly, by using liquid nitrogen for cold storage. Adding to the above, frozen thawed spermatozoa achieved pregnancies in vitro in IVF in 1984, in IUI in 1990, and in subzonal insemination in 1992 and ICSI in 1994. So when we begin to cryopreserve, the first effect is seen on the head where the acrosomal reaction takes place and where the chromatin and the DNA is affected, which is followed by the mitochondria in the midpiece and subsequently the tail. In case of any cryostress or cryo-injury, the plasma membrane undergoes apoptosis or cell damage. So how is sperm cryopreservation performed? Conventional freezing, slow freezing techniques are still widely used at ART clinics all over the world, but vitrification has become more effective for cryopreserving human spermatozoa after the efforts in the past decades. Vitrification by directly plunging the sperm samples into liquid nitrogen is a fast, simple, and a cost-effective method to cryopreserve human sperms. This method of rapid freezing causes no damage from intracellular ice crystallization during cooling, resulting in better motility and recovery, and better recovery with a higher mitochondrial activity. How sperm cryopreservation is performed? The preservation is done using cryoprotective agents, which are low molecular weight chemicals that serve to protect sperm from freezing damage or ice crystallization by decreasing the freezing point of materials. CPS can be toxic if used at a higher concentration. There are of 2 types, permeating CPS and non-permeating CPS. Permeating include DMSO, propylene glycerol, and glycerol, which penetrate the cell membrane basically, and they stabilize the cell plasma membrane protein and reduce the concentration of electrolytes. The non-permeating CPAs are sucrose, glycine, egg yolk citrate, which are unable to penetrate the plasma membrane. They minimize the intracellular crystallization by increasing the viscosity of the sample. Components of a cryoprotectant, they include a basic buffer and some additives. The basic buffer includes dilution and culture media. Dilution has phosphate buffer, test buffer, citrate buffer, and the culture media has human tubule fluid, human follicular fluid. Coming to the additives, during cryopreservation, the sperm cells might be subjected to rapid ATP depletion. Thus, they require glucose and fructose as replacements. The protein is an essential constituent which helps in osmolarity stabilization and maintain membrane integrity. Antibiotics are also required to prevent semen from microorganism contamination. Coming to membrane protectant, egg yolk is the inspiration of using the egg yolk is very simple, as it occurs naturally and should be tested first. Currently, the egg yolk is believed to predominantly act as a sperm cell membrane protectant. Antioxidants help to mitigate the oxidative stress caused during sperm freezing. Osmoprotectants, such as enzymatic inhibitors, EDTA, amino acids, are added to correct the abnormal semen osmolarity, which is usually increased or compromised post-ejaculate. Other molecules function mainly via increasing the concentration of cyclic AMPs, promoting sperm energy metabolism, thus improving motility parameters. Low doses of ozone was found to induce a positive response in the kinetic patterns and sperm structure. Since the discovery of glycerol, it remained the cryoprotectant of choice for cryopreservation, despite known toxic effect on spermatozoa. So to improve the cryosurvival rate, more complex dilutions were added as glycine, zwitterine, citrate, and egg yolk buffer, where earlier glycerol egg yolk citrate showed most promising results in terms of motility. During the 1980s, the two other complex cryoprotectants were added: human serum preservation medium (HSPM) and zwitterine buffer. Egg yolk, along with glycerol, may reduce the adverse effect on the cell membrane during sperm cooling phase. This suggests that glycerol egg yolk citrate medium is effective and has potential to be used in clinical practice. A drawback of egg yolk is that it is of animal origin and has potential of toxins or microbial contamination to the lab. Thus, other researchers have substituted egg yolk with lecithin to eliminate the health risk. Small comparison between yolk-free and egg yolk media. When comparing between two cryoprotectants, the use of glycerol egg yolk citrate yields a higher percentage of post-third normal sperm morphology, which was compared to the sperm freezing media, which can also be called yolk-free media. As the only FDA-approved commercial reagent for non-freezing storage of human spermatozoa, test yolk buffer has been applied in the pre-incubation of spermatozoa over the last 30 years and has proven to favor IUI and IVF outcomes. However, test yolk buffer was mostly used because of its ability to enhance the sperm penetration rate, but not to extend lifespan in vitro. Hence, spermatozoa are usually incubated in test yolk buffer for a short period within 2 hours and subsequently washed for IUI or IVF. The test tube buffer may be superior to other types of culture media, such as BWW. Notably, there are a few studies that report the fertilization outcome of sperm maintained in extenders for a longer time, which shows promise for more clinical applications. Paulson et al. Demonstrated that compared with the standard swim-up method, the refrigeration of sperm in a test tube buffer for 24 hours following density gradient method. These are certain papers which have shown that the use of egg yolk media has enhanced and improved the IUI, ICSI, and IVF outcomes. Some insights into the future. Potential components which could be used into sperm freezing media can be plasma-rich growth factor, haptourine, and insulin. Plasma-rich growth factor is extracted by simple centrifugation of fresh venous blood and adding anticoagulant and calcium chloride to it. It plays a role. It was found that a growth factor has a receptor on sperm cells and has a significant positive correlation between sperm count and motility. Haptourine is naturally present at both male and female reproductive tissue, and this acts as an antioxidant, anticapacitant, and osmoregulatory actions. Insulin is produced by beta cells of pancreatic of the pancreas. A positive impact of insulin and insulin-like growth factors have been demonstrated in development and function of Leydig cells. In this paper, the effect of plasma-rich growth factor could be seen. 3 different concentrations of PRGF has been used, 1%, 5%, and 10%, where we conclude that 1% has given us the best motility with more progressive motility and increased viability of sperm cells. Effect of haptourine on sperm cryopreservation. Supplementation has been proved by this paper, where we see wherever the haptourine supplementation was given, the vitality has increased, the motility had a good hike, and even the progressive motility has risen for the sperm cells. Effect of insulin on sperm cryopreservation. So in this paper and by this graph, we can conclude that with the increasing insulin concentrations, the progressive motility of the sperms was also on the rise. Thank you. And these are my references.
Yeah, thank you so much, Ashia, for that wonderful presentation. So I don't see any questions as of now. So we'll take one quick question from my end and we'll move to the next lecture. So have you seen any changes with respect to media? Say like if you're using different cryopreservation media, and is there any differential expression of them with respect to motility, DNA fragmentation, or any other survival rates also?
To be honest, we have just used 2 medias and we have experimented in those 2 medias, and on the lab level, we haven't seen any significant differences between the 2 medias.
Okay. With respect to only the motility part, or even the
survival, more or less it's the same. Survival, motility, morphology.
What about DNA fragmentation?
DNA fragmentation did not come into play. Like we did not even, I don't think so there was any effect on the integrity of the sperm.
Okay. So I can see one question here. Karsi sir wants to know cryoprotectants in vitrification.
Sorry?
He wants to know about cryoprotectants in vitrification.
Sperm vitrification, right?
Yeah. Of course, the talk is all about sperm, right?
Yeah. So we're using glycerol, glycine.
Ankit, I do have one question.
Yes, sir.
Yes, sir. Please, sir.
It is regarding the practice of many infertility specialists, especially those who are performing IUI. So they are sold the frozen samples by the so-called ART banks, saying that these are IUI ready and you do not need any further preparations or processing. So do you think those sperms which are frozen can be used just by thawing and instilling in the uterus?
Oh, that's a really nice question, sir. So actually the semen samples that we are getting from the sperm bank, so we look into the sample and since we are not noticing much debris, and then we also see a good survival rate, we see a good motility. So those are the indications which tell us that we could directly go ahead with the IUI before, like without, was that the question?
Yes.
No, that's the question, but
it's a part answer.
Yeah.
But don't you think there is a possibility of
Cryoprotectants.
anaphylaxis?
Yes.
Yeah.
I'm really sorry to interrupt in between. Can I add something into that?
Yes, please.
Sir, it's basically the procedure as well that we are using for freezing sperms, basically. Apparently, we are not using the normal protocol that we do for slow freezing, which is adding 1:1 ratio of cryoprotectant and sperm into it. It's the ultra rapid procedure, which involves a very little amount of cryoprotectant into sperm. Sorry.
Yeah, but this is just one isolated.
Yes,
thing.
sir. Yes, sir. I was trying to read about it, but then this is now very widely used. Even in Australia, we're getting sperms from US, and the protocol for them is like you just thaw the sperm, and it's ready to use. So there you're following the same protocol.
No, that I agree.
No.
My concern is something different, because not all the sperm banks are using the same protocol or using a similar amount.
Yes, sir. It's because they're not using that much of media to preserve sperm now.
Right. Still, the theoretical possibility of anaphylaxis exists.
Yes.
And even if a single case occurs, that may land you in trouble, a serious trouble.
Yes, sir.
Yes, sir.
So, my question, I mean, the extension of my previous question is thawing and processing, just simple washing is so detrimental that people try to avoid it.
So, but we do the post wash method, like we remove the cryoprotectant. All we are doing is we are giving simple wash and then swim up method. We are not doing density gradient for the samples which are coming from the bank.
Perfect, because they are already processed.
Yeah.
So
but we do undergo the proper wash method and then swim up method.
Yeah, so that is what I wanted to know, whether this practice should be advocated or not.
Always just to extend what Shukla has said now.
If with your kind permission, sir, if I can interfere.
Yes,
Hital Shukla here.
Yes, hi, sir. Please go ahead.
Yeah, see, it is the Shukla sir's question is perfectly okay, and it is very much theoretically, if we look at it, even our SOP also, NOAA's all SOP also says to give a very mild wash, simple basic wash, and then use irrespective of the procedure. And that is where the adverse effect of cryoprotectant like glycerol. Of course, the very least amount of cryoprotectant is there, but there is a possibility of some adverse effect, and probably one must avoid using directly. I think so.
Yeah. Right, sir. Yeah. So why Shukla sir brought this question is for the juniors, for the beginners. See, don't just try to thaw and directly load and give it to the clinicians. Always wash it once, remove the cryoprotectants. Then, if you're depending on the procedure, if you're going for IUI or IVF or ICSI, whatever it is, do swim up and then go ahead. Directly, just don't thaw it and hand it over to the for insemination or for injection, whatever it is. So, having said that,
your practice actually always, because all the juniors or maybe from bank you are getting message, you just directly you can use this, but just don't do this.
Yes, sir.
You just first wash it, then use it.
Right. So that is the message. So having said that, there are some more questions, but already we are late. So I would like to hand over the session to the coordinator. Thank you.
So after this very wonderful and informative discussion on the topic, we are moving towards the next topic, which is...
And see, Dr. Chandan is ready now, so we can take that.
Is my voice audible now?
Yes,
Yes,
Dr. Chandan, you can continue, please.
Dr. Charu, now Chandan is starting for his lecture.
Okay. So I think the biodata has already been read there. So it's you go ahead, Chandan, with your presentation.
Okay. Thank you for inviting me for all the esteemed faculties. Sorry for the technical glitch. There were a lot of issues in the things. So finally, the IT guy rectified it. So I'm without further delay, I'm starting sharing my slide. Hope my slide is visible.
Yes, sir.
Yeah, fine. Now, this session is all about how do we handle the sperm, or how do we cryopreserve it? What is the best technique to make sure that our ultimate aim is to make sure that we get a sperm without having any genetical damage or the DNA damage to it. So this topic is about the sperm cryopreservation. What we're going to review is first overview the current technique which we use in our cryopreservation procedure, considering the effect to result of the cryopreservation, the sperm cryo damage, what are the damage which occurs during the cryopreservation, how to optimize the semen cryopreservation. Interestingly, we have done a study to how to optimize with the media which we are available, irrespective of any media which we have in our market, but how we effectively cryopreserve the sperm. So I am going to tell you some certain examples which we have carried out in our lab. The sperm preparation prior to cryopreservation is cryopreservation induces DNA damage. Whether using fresh rather than a cryopreserved sperm has the same effect on the ICSI outcome, and what are the special and future issues which we are going to face. Now, what is sperm cryopreservation? As we have heard from our previous speaker, it is a procedure where we preserve the sperm cells, commonly called as sperm banking. Again, there are various reasons for sperm banking, whether it could be a husband may not be available during the procedures, or they might be undergoing for some chemotherapy procedures. So whatever the things are there, like there are certain situations where we have to preserve the semen parameter, sperm semen sample, in order to utilize wisely with respect to any of the ART procedure, could be an IUI or an IVF procedure. The first successful cryopreservation of spermatozoa was initiated almost like 50 years ago. In that, the first human sperm was the longest reported cryopreservation was like 22 years so far. So what happens here is it becomes in a dormant stage where all the biological activity ceases. The sperm, when we use a cryopreservation, our aim is to make sure that we of course there are certain DNA damage which occurs, which everybody knows that when we freeze the sperm to -197, of course there are some sperm damage which may occur, but how effectively we freeze is what our aim should be. Now, why cryopreservation is performed? Okay, when there is a very limited number of sperm or an abdominal semen parameter for cancer patient undergoing testicular surgeries, patient who suffer from degenerative illness like diabetes, sclerosis, spinal cord injuries, person in occupancy with significant of high risk of gonorrhotoxic environment. Again, vasectomy and sometimes varicose surgery. So before all this procedure, they just as a backup, we preserve the semen sample. How sperm cryopreservation is performed? There are again multiple debates which is there, and there are different protocols which we have, different type of medias, different steps are there. But basically, it is divided into a permeable media and the non-permeable media. Apart from this, again, if it comes to a debatable topic like whether it's a slow freezing or a rapid vitrification, is best. So again, that we're going to discuss in further. So in what happens in permeating media is it penetrates inside the plasma membrane. So now when we freeze the sperm our semen sample, all the water, we know that the cells are made up of 90% of water. So when it freezes, it forms crystals. So when the crystallization of the cells happen, then again it damages the cells. So now what we need to do is we have to dehydrate the cell first, then we allow the cryoprotectant to go inside. So you can see such of the permeating cryoprotectant, dimethyl acetate, dimethyl sulfoxide, glycerol, glycol, ethylene. There are a lot of combination provided by different media company, but these are all the penetrating permeable medias. And when coming to non-permeable, you have an albumin, dextran, egg yolk, citric, hydroxyethyl. So there are many, basically it is sucrose derivatives which we have. So the advantages here is it minimizes the intracellular crystallization by increasing viscosity of the sample. So you know this the viscosity when the osmosis and the reverse osmosis, when the viscosity is very high, any effect on that particular specimen or the object will be lesser. What are the benefit of cryopreservation? One is to maintain the sperm viability. It improves the recovery of motile sperm by using a specific buffer, which is called Zitterbrand buffer. And it improves the sperm membrane fluidity. Again, when we talk about the fluidity, it's very important because the cell organelles, when it has to perform in an optimal level, the sperm fluidity is very much important. So that's why so far in the previous lecture, we were asked some of the questions where whether initially like a post-thaw without processing, will you give the sample for the IUI processing? So definitely, yes, it is not. You're not supposed to give just like, see, the basic, what does the vendor say is like when you get a sample from a sperm bank, what they say is to make the clinician or the person who does the IUI to make their work easier. What they say is, you just take the sample, keep it for some time, get it to room temperature, and then use it. But what really happens here is all the receptors are blocked by the cryoprotectant. So you have to give it a wash. So once you give it the wash, you have to make sure the sperms are become active. So what is happening in the active is the fluidity of the sperm will be in optimal condition. When the fluidity is become optimal, all the cell organelles will become optimal in condition. Okay. So so that for that fluidity is very important. And again, when this are very optimal, obviously the sperm which has to cross the mucosal area, cross the cervix, cross the uterus, and reaches the fundus, for this the sperm should be in optimal condition. So now again, coming to slow freezing, I don't know how many of you are following this thing, but there are many misconceptions about slow freezing, and I have personally seen some people are freezing in a different way. I'll tell you an example how I have seen and how I have practiced in my center. See, when you freeze the semen sample, obviously you take 1:1 or 1:1.5 ratio of the media and the semen volume. So you mix it. So when you mix it by drop or mix it properly, like whatever the techniques you are there, I'm not touching that. You might be best in that. But what I've seen the error which happens here is, and which can cause high DNA fragmentation is, once the sample is ready, once your mixing is done, whichever the way you like, what I've seen is they keep this sample in a refrigerator, which is 6 to 7, then goes to the freezer, then goes to the liquid nitrogen vapor, and finally it goes to the liquid nitrogen. So you have different intermediate step which is happening. See, any cells, whether it might be an oocyte or a sperm, it is just a cell. So we stop completely slow vitrification procedure, which we followed like 1 degree rise in temperature for the embryo preservation, which is followed very long back. We have stopped using it. That is completely out of syllabus now. But that is also a cell where we know what is the effect of slow freezing for an embryo. Even here, the sperm is also a cell. This is almost like a slow freezing, like where you subject them and slowly increase in temperature. What happens is there is a lot of DNA damage. We personally studied maybe almost 25 to 30 samples with a conventional way, how they do the freezing. And then what we have done is we have mixed the sample 1:1 ml or 1.5 ml ratio of media. So after mixing it, we just hardly keep for 5 minutes in room temperature. Then the entire vial directly goes into the liquid nitrogen. It's like a rapid vitrification. It's never called as slow freezing. It's a rapid vitrification. So when we have done the analysis of both the sample, the one which we freeze the sample directly into the liquid nitrogen has a very less DNA damage. And the other conventional way where they subject into 3 state where we have found high DNA fragmentation. So this is one of the tips which you can follow, and you can just do your homework in your particular lab, do this method and check out which just has a high DFI in it. Okay, so I don't want to press on this thing. I think, yeah, you know what are the disposables which we use in the cryopreservation techniques. Okay, and again, this is what I was talking about. The labeling of the vial which you keep is also very important to make sure that you take the sample without disturbing the other sample. You take the exact sample which you want. Okay, so this is what I was talking about, the ultra rapid freezing, which we called a vitrification protocol for the sperm rather than freezing protocol. Okay, there are guidelines which is given by ISHRAE and the WHO, but all says that your DNA fragmentation should be lesser. And I have seen one more group of people where they freeze the sample after processing it. So they process the semen sample, the processed 0.5 ml or 1 ml, whatever the final things you get, they freeze this sample. They again, for that, they will add 1:1 or 1:1 ratio of media. But what we have observed is when you freeze a raw sample compared to a processed semen sample, a raw sample survivability is quite higher, because so far what we are concentrating is only on the sperm, the cryoprotectant, all this thing. But what we are forgetting is the seminal fluid, which is a big science in the seminal fluid. It's not just a fluid where the sperm swims. It is a big science which is there to make sure that the seminal fluid are always support you to the sperm to make sure that they reach to the fallopian tube. So seminal fluid also supports the what do you call it, the post-thaw. The seminal fluid will have a easily available enzymes and the protein that can be easily taken up by the sperm rather than a synthetic protein which we are providing in the form of an ATP. An ATP which is naturally available in a semen parameter, where the sperms are very much used to it, they take up that more faster than the synthetic media. Still, there is a big science where our media or the media's ingredient, media's what are the constituents are there. It is still big debate, or the data which is debate is going on, where whether this media which they have is sufficiently used by either a oocyte or the sperm, or still it is just like subjected to the sperm or the gamete usage. So that's why we have a sequential media or the what do you call it, as a single step media where let the gamete choose their own. So there is a big debate still going on the synthetic media. But when we talk about the natural media or the natural proteins which are there, where the sperms are easily, the sperms can take up those protein very easily. Those are the things which are very much important during the post-thaw. And post-thaw, what I have seen is, again, there is one more experiment which we have done. Maybe all this small experiments might be useful for the beginners who are there. Post-thaw, what they do, they take the sample, keep it in room temperature, get it to make sure that liquefy by itself, then they process it. But again, this is not the right way. But what I personally do is take the sample, and once it has come out from the liquid nitrogen, we directly immerse into maybe 25 to 30 degree water bath, so that the sample liquefied rapidly. Again, when it's slow thawing, again, the crystals can damage the cell. So when there is rapid thawing, just like how we do for our embryos, so this will not form any crystals, so that the sperms will have a high, good form of DNA in it. Okay, this is what we discussed pre-freeze and post-thaw. So I will always go for the freezing the sample without processing it. Okay, I don't want to touch on all this thing. DNA damage. Okay. So DNA damage, this is what we were discussing so far. Okay, this is a big issue. Okay. Now, coming to the last slide. Now, how effectively you can freeze your semen sample to make sure that you get a optimal DNA integrity. It's not only the cells which we get are post-thaw, but the cells which you got should have an optimal DNA integrity. So one method which I told is to make sure that you process the sample along with the raw semen fluid, not with the processed one. So when it comes to a future issue, the cryopreservation of human semen is extremely important to the field of male fertility. Nowadays, again, the male ratios are very much increasing, especially post-COVID. We have seen a drastic change in the either the embryo formation or with respect to the sperm, which we have seen. So cryopreservation plays a very important role. Today, there is no agreement in the literature on whether or not to cryopreservation effects on sperm chromatin integrity, or on the use of unique and functional protocol for the freezing thawing procedure. So though there are not like proper evidence which says that this is the right protocol where you have to make sure that this will give you the best result, but it is all up to our experience and our own research to make sure that which protocol will remain best with respect to our lab condition. So this is about the topic which I wanted to discuss today. Sorry for the technical issues which we faced initially, and I thank for the entire committee for giving me an opportunity to share my knowledge which we had, and I wish all the best for my fellow speakers. Thank you so much.
Thank you, Chandan, for such nice deliberation. I have one question here, which usually asked by the clinicians or the sample when the frozen sample is thawed. In your experience, what one should expect the post-thaw recovery in terms of motility and motility of the sperm post-thaw? When they thaw sample for ICSI or IVF or maybe for IUI, what they should expect?
See,
what percentage?
When it comes to the clinician point of view, it's like for them, if you have frozen 50 million sperm and it's 80% active, they want the same sperm to be retrieved back. But practically, it is not possible, because I'll tell you a simple logic in this. When you mix the sample, say for example, let it comes to not in million, let it take it in hundreds. So when you have 100 sperm in a semen, when you mix the cryoprotectant in it, you are not making sure that all the 100 sperms are mixed with the cryoprotectant. So when you obviously thaw, definitely those sperm which are not protected by the cryoprotectant, obviously they'll die. So we cannot expect the recovery on it. So when as an answerable person, as an embryologist or an andrologist to a clinician, it is our responsibility to explain and make them understand the science behind it. It's not like when you freeze 100, you'll get 100 sperms back.
So what is cutoff? Means like suppose you have frozen with 100% motility. So post how much you should
50 to 60%. If you can recover, that's your best protocol which you're following. At least 50 to 60%.
Yeah, I also think so. Minimum 50-60% survival should be there.
That's true.
In a wash sample. But if we freeze a raw sample, then can we expect some more percentage of motility?
Raw sample frozen and thawed?
Yeah.
Yes, I have seen this. Raw sample freezing and thawing, their survival and the survival viability is more higher than the process sample. And the DNA integrity is also more stable in the raw sample.
Okay. So is there any question?
I have one question. Sir, I have one question, sir.
Yeah.
Chandan, just now, just to extend the point. See, as far as I know, the spermatozoa are not supposed to be there in the plasma for longer periods, right? Because it just acts as a medium for a shorter period of time. Once even in my also, once the deposition is over, once the acidic environment gets over, neutralizes, the sperms just get out of it, right? So it's always preferably maybe the cryo survival rates might be better, but at molecular level, we don't know what exactly is happening. So it's always best to process the sample, get out of the plasma, fish out all the spermatozoa from the plasma, then you freeze it, because see that even naturally also that is what is going to happen, right?
Okay, so what happens here is even short period. When it comes to, I'll go with your way of thinking in it. Yes, short period is there. But even here, when we free the sample, it is just for a short period. We will not expose it for such a long duration. So when the sample is collected, obviously we wait for the liquefaction to happen. But we are making sure that the sample is liquefied so that the proteolytic enzyme which is there on the semen sample will favor the seminal plasma to liquefy, so that the energies are free radical, and this free radical energy is utilized by the sperm. So that's why when we generally say, no, don't see the observation of the viscous sample, make sure they liquefy. So when they liquefy, the proteins are available for the sperm so that they will become active. So though they are staying for a certain short period, once it crosses the vaginal acidic environment, it's a matter of short period. When we process the semen sample for a freezing, we are not leaving the semen sample for longer duration. There is something called an half-life.
No, I was talking about freezing of raw semen sample. You mentioned, right? Freezing of raw semen sample.
That's where I'm coming.
That was my point.
So now, for any medium or any cells or anything in a life, in a scientific life, there is something called an half-life period. So though the sperms are there in the seminal fluid will have certain half-life period where the environment will be optimal for the sperm. Now, what happens when we free the semen sample? Obviously, we never wait for long time. Anyway, we take the sample, wait for maybe half an hour, 1 hour, and freeze the raw sample. I agree. Your question is like, why do you freeze a raw sample? So when you freeze a raw sample, when you thaw it back, again the duration, when we all focus about the timing, the duration is very short. Maybe before thaw, maybe 1 hour, we wait and then freeze it. Post thaw, maybe we'll wait for 15 to 20 minutes, we'll thaw. So the seminal fluid will not cross the half-life period. Before the half-life period, it makes sure that the natural proteins which are there, or the natural ATP which are there.
No, but what happens is, when you're even at the time of storage also, they'll be in the atmosphere of the plasma, right? So which actually there is no, like 0% activity won't be there. Matlab, some activity will be there, right? So it's always better to remove them and freeze it, is what I feel. Maybe you can extend the
that's
point.
right. That's what our all the viewers who are there, they're going to do their experiment in their thing in their lab, and they may find out in a better way.
Yes, I checked
that. Can I add something? I think one area where probably it's going to help processing is when you are going to have severe oat sample, and we will not be freezing, say, where we have less than 0.01 million cases. And in such cases, when the volume is more, in such cases, it would definitely help to process and freeze them. Because I'm not very sure about the DNA damage, because as I've not done a study for that. But definitely the number of sperms which are going to be available post your thaw, because limitation of the volume, those will be more. So when you have severe oats, say you have a 2 ml, 3 ml sample, in those cases, processing and freezing would definitely help.
I agree for that, because the count is very less.
Count is very less.
Because recovery rates will be very good.
Recovery rates are very low. And I'm not sure, like you had said, 50 to 60% as the survival. Little difference, not huge. For the juniors, say, if you have anything about 30 or 40% you begin with, and 50 to 60 probably competency level, and there'll be a huge difference. Like some samples just don't survive in spite of the best protocol what you're having for cryopreservation. Your recovery rates might be less than 10% also, and some samples survive just like 90% plus. So mean, there was a study which said that 30 to 40% is a good survival. Probably we have not been considering so much in terms of survival percentage because it's a problem of the lot. We have lots of sperms available. So I feel the cryopreservation for sperm as such has not been optimized as well as it is for the oocyte and the embryo.
Hello. Yeah, I think it's I fully agree with Dr. Akash. Sanjay, do we have any other question box?
I think no, sir. There are some questions, but I think it's all overlapping.
Okay, so anyway, we are also having running late of time also. So thank you, Dr. Chandan, for your participation. Over to the coordinators for further talk.
I also wanted to say something that this discussion was all worth waiting for. So now moving towards the next topic. Can everyone hear me?
Yeah, Nancy.
Yes, Nancy. Yeah, go ahead.
Now moving towards the next topic, that is various method of sperm freezing from semen to a single sperm. For that, I would like to call Dr. Akash for moderating the session. Sir is MBBS ASHRAE certified embryologist. He is scientific director of Hedge Fertility Hyderabad. He is an alumni of Osmania Medical College. He's practicing male fertility and embryology since 2011. He's topper of ASHRAE Clinical Embryology in 2019 Vienna. Is actively involved in academics and has co-authored a book chapter also. Is active member of many national and international fertility organizations like ASHRAE, ISAR, IFS, and ACE. Participated in many national conferences as a faculty and conducted many multiple workshops in andrology and embryology, including the vitrification and IUI workshop. His keen interest is in male fertility treatment with surgically retrieved sperm. I would like to hand over it to Dr. Akash for the speaker's introduction, please.
Yeah. Thank you, Dr. Nancy, for the introduction. And I would like to welcome Mr. Harsh Kalra. He's presently working as senior embryologist in Australia. And right now he is associated as a senior embryologist with Apollo Sarita Vihar, New Delhi. His specialization includes genetics, molecular biology, and reproductive sciences. He has a master's in clinical embryology from Monash and trained in the research and ART techniques from Monash University. He has co-authored papers in journals and books. Welcome, Mr. Harsh. And just before we start the topic, we had some wonderful discussion about what are the various media that we are using, what are the effects that we are having of the cryopreservation, thanks to our earlier speakers, thanks to Chandan and Ashia, and the lovely discussion. And this will amalgamate into what are the various techniques that you are going to apply, whether it's a single sperm or the multiple sperms or the raw semen or processed. So waiting for your lecture, Ethan. Mr. Harsh.
Thank you, sir. Thank you so much.
Yeah.
So I'll just share my screen. Is my screen visible?
Yes, sir.
Yeah, sure.
Sorry. So thank you so much for inviting me for this lovely evening. Basically, I'll be discussing more about the various methods for sperm freezing and from semen to a single sperm. Introduction. With introduction, sperm freezing really started with freezing of sperm into a snow, but that was something around 200 years ago. The whole approach changed when we had the discovery of glycerol as a cryoprotectant agent by Pollard. The first human live birth using cryopreserved sperm was reported in 1953 by Bungie and Sherman. The longest reported success of storage of sperm is 22 years for human sperm. The main objectives of this topic will be introduction of sperm freezing, cryoprotective agent, sperm freezing method, advanced sperm freezing methods and devices, and single sperm vitrification. Introduction. Sperm may be stored for patients with limited number of sperms or abnormal semen parameters patients suffering from illness, patients with ejaculatory problems, and fertility, basically for fertility preservation. Spermatozoa are small cells with a large surface area, making them less susceptible to damage. Pre-freezing semen quality parameters such as sperm motility, abstinent periods affects the cryopreservation of cryosurvival rate of the poster sperm. Spermatozoa with abnormal motility or particular susceptibility to cryo damage, thereby reducing their fertilization ability. Concentration of cryoprotective agents as well as membrane stability additives is correlated with the rate of sensitivity of spermatozoa to sub-zero temperature. In order to protect cells against damage, cryoprotective agents are used. We have already discussed in depth about these things. They're basically of two types: permeating cryoprotective agents and non-permeating cryoprotective agents. So I will not go into a discussion about these. Benefits, yes, they help in maintaining sperm viability, improve sperm membrane fluidity, increase sperm longevity and survival, improves recovery of motile sperm, increase ability of sperm to penetrate the cervical mucus post-thaw. These are some of the commercial available medias, Kidzato media, Queen's Advantage, which are very easily available and widely used. Sperm cryopreservation methods. Basically, we have three different methods: slow freeze, rapid freeze, and ultra rapid freeze protocols. For technique to be suitable, basically depends on the lab that is using them. We'll start with slow freezing. Well, slow freezing was the first method which was widely used for sperm cryopreservation. It's basically depends on dehydration. So the cryoprotective agents is added to the sperm, and it's been it compromises, and the temperature is reduced slowly. It comprises gradually cooling of cells into 2 or 3 steps within 2 to 4 manually or automatically using a programmable machine. The method uses maximum cooling rate that results in adequate osmotic dehydration to maintain the cell water's chemical potential near an equilibrium. Manual slow freezing. I think this is the most widely used method in the labs, where cryoprotectant is added to sperm step by step. This actually helps in maintaining the osmolarity of maintaining the integrity of the sperm. Sperm sample is gradually cooled from room temperature to 5 degrees centigrade at a rate of 0.5 to 1 degree centigrade per minute. And then finally it's been plunged into liquid nitrogen at minus 196. The other method which is used is programmable freezing, which is not widely used because it's expensive. The instruments used for it's expensive, so it's not widely used, but then it is used. Programmable freezers use a plate to hold the straws and cooled by liquid nitrogen held in a storage tank under the plate. Liquid nitrogen is poured into the tank. The program machine uses software data to obtain the cooling from 20 to minus 80. And after completion of freezing, the straws are removed and stored into liquid nitrogen. Rapid cooling, this is another method that is now in use. In rapid freezing techniques, spermatozoa are mixed with cryoprotectants, and the suspension is loaded into a cryo straw or cryo vial for 10 minutes above liquid nitrogen. So basically, it's in the vapor state. The temperature in the vapor state something varies from minus 70 to minus 10. So it actually starts dropping, not at a sudden rate, but then it's lower rate. And the LN2 vapor phase provides a thermal gradient due to the distance of the volume to the liquid. And the studies have been done, which is comparing the slow and rapid freezing methods, which says that significantly greater rate of chromatin deterioration is observed in rapid cooling compared to slow freezing. Ultra rapid freeze, this is another method that is being used, and it's been used mostly in sperm freezing for by, I think, most of the sperm banks. This method is used to store human spermatozoa by minimizing cryoprotectants. The sperm cells are cooled in an ultra rapid manner, which is more like a vitrification method. The suspension is plunged directly into liquid nitrogen, and it's been done in 2012. And the pregnancy was recorded for 2 healthy babies in that year. It is believed that kinetic vitrification is more suitable as spermatozoa are separated from seminal plasm. Before cryopreservation and warmed spermatozoa do not need an additional centrifugation step for plasma removal after that. This is another method which is being used now. It's more about, it's also known as freeze drying method. It does not require liquid nitrogen. Freeze dried sperms are kept at 4 degrees centigrade. It's very widely used for transporting sperms as it can be done in dry ice as well. The DNA damage was has decreased compared to the liquid nitrogen, but then most of the sperms are not retrieved in the motile state. It's and due to which due to the retrieval of the immotile sperms, it's been mostly used for in the cases with ICSI. For optimizing the semen cryopreservation, these are two factors we should consider. One is genetic factor, which is more about sexual abstinence, seminal fluid quality, and seminal quality. The technical factors mostly include cryopreservation media, method that is being used, and the cooling rate, storage, thawing, and storage temperature. Single sperm freezing now. Single sperm freezing is mostly used for the patients with such as oats, patients which can't really produce samples, and it was mostly discovered with the first with the use of empty zona pellucida. And since then, a multitude of cryopreservation techniques have been developed to improve sperm count and motility. Conventional freezing methods are not suitable for freezing small number of spermatozoa. Sperm samples are diluted in large volume of cryoprotectant, and recovery may get difficult. To prevent this loss, a small number of spermatozoa are stored in biological or non-biological carriers. Microvolume aliquots or spermatozoa can be stored, and biocarriers such as empty zona pellucida and non-biological carriers such as cryoloops, micro droplets, mini straws, HSV, all these are in place to use. Biological carriers. Zona pellucida was the first carrier developed for low number of cryopreservation of spermatozoa. And after the removal of cellular material from embryos to oocytes, the resulting empty zona can be used for storing sperms. Microspheres were also used, which are made of agar. The algae which is used is called Volvox globata, and is being used to make these microspheres, which are not FDA approved, and for the same reason they're not allowed, or they're not actually being used widely, because the residues of the allergenic acid is present on the sperms, and which affects the sperm motility, and it's not being researched yet. These are two carriers, the biological carriers that are being used. One is hollow core agarose capsule, and the other one is Volvox glabto sphere. The other method is cryoloop. It's very similar to the one which we use for embryo freezing. It's been again used for patients where we have a low number of sperms. The cryoloop consists of a nylon loop that can trap a small number of sperm in the loop with the help of capillary action. And advantages include ease of retrieval, minimal sample loss, and the drawback is it's an open system, and it's very easy to have contamination because of liquid nitrogen. This is another device which has been used for storing low number of samples. It's called cell sleeper vials, and the other method is cryotops. The other device is cryotops. Small number of sperms contained in the microdroplets are stored in this dish, and it can be stored in the cryo vial, further which can be stored in the tank. Similarly, cryotop is also being used for storing low number of sperms. The other method is straws and excipient. So they are also used for storing sperms. They are not widely used because, again, uh, they do break very quickly. And the other method, the other device which has been used is the high security device, which was developed in 2012 by Desai and his colleagues. The reported successful pregnancy using this method is good, and the system is closed and does not require interaction with human sperm or animal products. Microstraw, this is another device. It's very small, and it can be loaded in the same dish as your ICSI dish, and then the sperms can be added into it, and then again further it can be stored in a cryo well and into which can be stored into your tank. Sperm VD device, it's another device that's being used. Small droplets are made onto the dish, and the sperms are stored into that. Further, this dish is loaded into cryo vial, and that's plunged into liquid nitrogen straight away. Further, this can be stored in the tank in the cryo vial. These are the various devices which are being used for cryopreserving sperms. It involves zona pellucida, cryoloop, cryoleaf, droplets, microstraw, micropills. All these devices are widely used for a low number of sperms. In conclusion, cryoprotectants and the method that you're using for freezing sperm is really important. And sperm can be cryopreserved using different methods. It just depends on which is available in your lab. And suitability of cryopreservation technique is dependent on the ability of spermatozoa membrane to withstand the freezing and thawing process. Sperm cryopreservation is an efficient tool in managing infertility. In order to optimize sperm cryopreservation, both biological as well as technical factors should be taken in consideration. And advanced methods such as using biological or non-biological carriers for freezing single to few sperms are aimed at this and have produced the desired results. And that's thank you.
Thank you, Dr. Harsh, for the elaborate presentation on the various methods available. If I may add one thing, like I think with, like you have shown the sleeper is available methods and your VD devices are there, sperm VD. I think biological, they don't have any more role with the availability of this much role to play with sperm VD device available. And
that's true.
Yeah, and this,
but then again, I would want to add into that the sperm VD device, as far as I know, it's really expensive to procure, and it's not readily available as well. Like
I think
so
in India, availability is there quite freely. I guess in India right now, might be 2-3 years back, it was different. It was launched 2018-19 that time. And for biological carriers, then if you put, then how is it that would be in terms of, putting a sperm inside a zona and recovering that?
Biological carriers are not, yes, they're not widely used either.
Yeah, so I think VD would be the more probable solution, more efficient one, with recovery rates, they say, of 90%, 90% plus 92, 94%, they say. And have you found any difference when there's any sperm freezing, when you go in for sperm freezing with respect to a low number of volume of sperms versus when the content motility is normal? So for the benefit of our audience, can you just elaborate on that? Any difference?
I would actually want to add into that. The sperm survival is solely not dependent on the device that you're using. It's the technique, it's the cryoprotectant media that you're using, it's the technical expertise, how you're storing it. All those factors are responsible for a good survival end of the day. So just not the device, just not the cryoprotectant, it's everything comes together. So yes, the survival is good with the device, but then again depends on which media you're using, how you doing the whole process, because I think there is contamination with oil as well. How you making sure that you're taking oil away from that device. So all those factors need to be addressed as well at the same time when you're actually freezing these sperms. So it does vary from place to place. from person to person. That's what
Yeah.
I think.
Yeah. Because the biggest scare would be when you do a teaser or say
Yeah.
a micro teaser earlier, and finding the sperm first of all, it would be so difficult. And upon that, you freeze and unfreeze, and don't know the number of eggs that you're going to get, especially if
Yeah,
it's a
true.
case of trial teaser. I think we don't have any other further questions, so we'll be moving forward over to the coordinators.
Not question, but I have a comment.
Yes, sir.
Yes, sir.
So first, let me congratulate Harsh. He has done
Thank you, sir.
good job. So as far as the availability of the devices is concerned, so neither the biological devices are available that easily. So
Yes,
in
sir.
fact, those availability of those things are, I think, rather more difficult than the availability of these devices. So that is one thing. Another thing is about the lyophilization. You mentioned it, you touched it. But in my opinion, as far as my knowledge goes, I think the DNA integrity is concerned. The DNA damage is more or less similar to the technique that we use in liquid nitrogen. Along with that, you require a large lyophilizing machine for that, which is not very user-friendly thing. So for day-to-day practices, lyophilization may not be a very feasible thing. Of course, in animal farming, they are using it for a long time, but there are challenges with lyophilization. So this is just 2 cents from me.
What the 2 cents are for sure.
Thank you to all the speakers, and thank you, sir. And coming to, after all the learning, now we begin the segment of our visualization. For this, we have brought 3 wonderful video demonstrations for you, all of you. And the moderators of the session are Ved Prakash, sir. Can I have the CV, please? Sir is the founder of ejaculating, past president Academy ACE 2020-22.
It's okay. You just read.
No need for introduction, sir, to be honest. And Rahul, sir, is that
yeah, start up with the video, Nidhi. Yeah.
Yes, sir. So please take over, sir. Rahul,
Yeah,
sir.
yeah, please.
Yes.
Thank you, Nidhi. So we will starting our video demonstration. So in lectures we have learned so many things from our previous speakers, from cryopreservation effect on sperm, then different media and different devices. Now it is time for video demonstration. So first speaker is Dr. Hetal Kumar Shukla. He is the chief andrologist in Nova IVF Fertility since 2015 onward, and he's got award in Icon of the Year, Andrology National ET Health Award. He is member of ACE Academy of Clinical Embryology India, visiting faculty Gujarat Biotechnology Research Center, Gandhinagar, and he is the team member of IHERA, authored a chapter in a series of books published in collaboration with TV Spain. Chapter title was Semen Analysis and Semen Preparation in Infertility Management Series Handbook, and worked for Management of Nature Conservation, United Arab Emirates in 2009 to 2015, and worked for Sabarmati Ashram Goshala, managed by National Dairy Development Board, bovine semen freezing, multiple ovulation and embryo transfer IVF from October 1996 to January 2009. Over to Dr. Hetal Shukla. Dr. Hetal, you can start, please.
Sir,
You can start the screen sharing.
not,
Dr. Hetal, can you start the video because the video is not visible to us.
Hello.
Yes.
Just a minute. Something happened. I will share it.
Sir, is there any issue in
Just
playing
a
the
minute.
video, sharing the screen, sir?
Just a minute.
Okay, sir.
Is it okay now?
No, we are not able to.
No, you can share the screen first, then you start the play for the video.
Dr. Hital, you have to share your
Visible
screen.
now?
No, sir, it's not.
No, it's not.
You have
The
to
screen
share
is
your
not
screen.
shared, sir. Screen is still
You have
not
to share
shared.
your screen.
Sir, you need to start share screen and then start the video, sir.
Screen, start recording.
Sir, I request you to please click on share screen and then click on play button.
Yeah. I'm doing that. I don't know why.
So when you're opening the share screen, there are two options: share sound and optimize video clip. So just tick on them, sir, and then just share the whole computer screen, laptop screen. Hello.
Is it okay now?
You can start your video. We can see your screen. What you can
I
do
think
is,
this is Nidhi's screen.
Nidhi Singh ma'am
Nidhi,
is
Nidhi, you have to stop screen sharing.
okay. So
Nidhi, your screen is visible. Yeah. Hital, now you can start. Share screen.
I don't know why it is not.
or in between, sir, can
We can
start with the
Dr.
next.
Prasad is here. We can start with Dr. Prasad.
We can have the video. Dr. Munang Guru Prasad, you have the video with you. You can unmute yourself.
Hital, can you share that video to me? From here, I will play that video.
Yeah, Dr. Prasad, can you unmute yourself? Yeah.
I'm able to hear me.
Yeah.
Yes, sir.
Now it's fine. Now it's.
Can I go ahead?
Yeah,
Yes,
you
sir.
can go ahead. Dr. Prasad is going to present a video on testicular sperm preparation for sperm freezing. Yeah, Dr. Prasad, please.
Before that, you have to introduce him, yeah. Yeah. Suman, please share
the slide.
share your screen.
Yes, sir.
Yeah.
Yes, Dr. Prasad, he's a doctorate in reproductive physiology, hails from Tirupati, trained in Midland Fertility Services, UK, working as an embryologist since 28 years from Hyderabad, and published papers in national and international journals. He is associated with the first IVF baby twin of twin states. Yes, Dr. Prasad,
Yeah.
can share this.
Right.
Yes, sir, you can share the screens.
Yeah. Am I audible now?
Yes.
Yes, sir.
Yeah.
Yes.
I thank the organization ERA for giving this opportunity as a first time. I'm seeing all you people, and really I'm happy for the the ongoing things that you are making the people to know. Yeah, today my topic will be the testicular sperm preparation and freezing. Yeah, many agesthemic men maintain sperm production at varying levels of the testis. Several surgical methods evolved to collect these sperms. The major surgical procedures that we come across is PISA, MESA, TISA, TZ and micro TZ. These are the most of the time PISA and MESA do not require any mechanical separation of sperms, but TISA and TZ or micro TZ requires mechanical separation of the sperms from testicular tissue. This is only just to give an idea. The needle puncturing is a TISA and taking out one small piece is a TZ. And this is the general, everyone knows that using a simple syringe with a negative pressure, aspirating the seminous tubules, pull out the whatever is possible, and then they squeeze them into pieces, and then different ways to how to make it into small pieces, and then search for the sperms. Sometimes the collagen can help used in cases of difficult samples, which helps in degrading the testicular tissue. In case of blood stain, give a 10 seconds of a quick spin where the RBC can be segmented and supernatant can be used for the sperm source. See, in my experience, let me show you the procedure what I follow. See, tissues collected by TISA or TZ requires minimum 15 to 20 minutes to process it. Let me show you first the video and then explain the things. Yeah, what I usually is take a cup like the small cap. Sorry, what you see is a round structure is nothing but in a coffee filter, where you find a stainless mesh in that, and then or any stainless steel small piece of a mesh also can serve the purpose. And what you need is a two petri plates with a medium and 2cc syringe. Now you can see the seminiferous tubules which are washed in the medium thoroughly, and place this seminiferous tubules on the mesh. And down you can find one more empty plate, petri plate. Slowly discard the, place the seminiferous tubules, and first immediately try to wet the tissue with the medium so that it won't dry out. Then take out the piston of the 2cc syringe and try to smash the tissue on the mesh slowly, gently. and then wash the mesh with medium, and the downstream water that is collecting will be having the source of a sperm. And again, once again, you try to smash the tissue gently. And wash with the medium. And whatever that you collect the sample as medium, when you examine it, you can see the sperms. So those sperms are further frozen and then can be used whatever that way that we can. So the whole procedure, in general, the previous video that what I've shown you, minimum time it takes 15 to 2 minutes, 20 minutes. But the video the way that what I do is takes just 1-2 minutes. The most advantage with this way that what I do is saves embryologist time and stress. Sample exposure time is minimized, reduces the anesthesia time. And whatever the sample that we acquire, if there are good number of sperms, we can use a slow freezing. And these sperms are very low, then we use a vitrification method to freeze the sperms. And future life is in tanks now, cryopreservation, hope in a tank now. And this is only to show you the slow and vitrification how it takes. Slow freezing is a drop-down temperature, and vitrification is all of a sudden into low temperatures. Post-star sperm samples is the only one major problem that what we face is most of the time sperms will be immotile. Then it's a question is the vitality. In general, everybody uses this hyposmatic solution, pentoxifylline, theophylline, or laser shot. Among all of them, I find the radium media which are available with theophylline are better, give you better results. And in case of very slow, very low number of 4 to 5 sperms to be frozen, the vitrification device, which is shown here, is ideal to use it out. And at the end, I say advanced method should give a chance to every infertile male to become a genetic father. Thank you.
Thank you, Dr. Prasad. It was very nice and excellent. And I think it is very good method and very simple. Everybody can use this method. Can we move to first one? No, I received that, that presentation from Dr. Ethan. I will share my screen. Dr. Prasad, can you please stop sharing?
Sir, I could not follow.
You have to stop sharing your screen. No?
Stop sharing this.
Stop sharing, sorry.
Yeah. Okay.
Thank you.
It's done. We can have all the video presentations now, and after that we'll be having the question and answers. Yeah. So please share.
Yeah. My God, I don't know why it is.
There's an error.
There is some problem here.
If you can re-download the file and then play this again, or
what? Okay. Again, I have to try. Actually, I don't know why it's not done.
Keshav is here.
Keshav is ready with this.
Yeah, I think we can have the video from Keshav.
No, yeah, it is not running. Actually, there is some problem with this video.
Yeah, can I have the slides for Keshav? Mr. Suman, can you please share the slides?
Prasad sir, your mic is on, sir.
Nidhi, can I have the slide of for Keshav's introduction?
Yes, sir.
Yeah, please share.
Sahiti, please share the file.
Sahiti.
So is the slide visible, sir?
Yes, Nidhi. So sorry for this glitch. I think we can have a next video with us, and this video will be presented by Dr. Keshav Malhotra, and he's the very much renowned embryologist in India, and he holds a master degree in clinical embryology from Monash, and one of the few ASHRAE certified embryologists from India, and he is the lab director of Rainbow IVF and now the director of Malhotra Embryology Training Academy. Keshav, the stage
Sure.
was just, yeah.
First of all, I want to thank Keshav Malhotra because I called him to tell some junior to present the video, and he agreed. He's told me that I will do, sir, for that there is no issue. So thank you so much, Keshav, for coming. Thank you.
Thank you, sir. And it's such a pleasure to join all of you here. Is the video visible? I've not played it yet, but is it visible?
Yes, we can see. Yes.
Yes, sir.
Okay, perfect. So whenever we're doing sperm vitrification with sperm VD, I think the first thing that you need to really understand is the consumables that you need. So basically you would need the vitrification device, which is right here. You also need a dish. Now I am using the sperm VD dish, which is specifically made for sperm VD. This is not available in India as of now. I got it from ASHRAE, but you can use any Petri dish or even a Nixie dish in this scenario. You will need PVP, you'll need mops or hippies, and you would also need oil, and you'll need a Eppendorf pipette as well. Right. Now, the first thing that you need to do is to basically prepare the dish itself. So use any volume that you want. Like I generally make a 10 microliter droplet when I'm doing ICSI. So I use the same droplets when I'm doing sperm VD. And basically what you would want to do is create about, let's say 3 to 6 droplets just for the sperm solution. First drop would be from PVP. So this would help you to just stabilize your needle and the aspiration pressure, and remaining droplets that you create would be of mops or hippies. Again, use whatever volume that you are currently using. I generally make a 10 microliter droplet. All right. You would want to make, now if you're using a Petri dish, you would want to make it in such a way that there is enough space left for the device to be put inside. So make it towards, like shift it towards the periphery a little bit. If you're using this dish, you can actually see that it has a specific allocation for the device. So you're really not worried about where to place the device. You have to cover it adequately with oil. Now, this is an important step because when you're placing the device into the dish, most of the times what will happen is if you've not covered it properly with oil, especially if you're using a regular ICSI dish, then in those scenarios, the droplets of the device would be above oil, and that's not an ideal scenario. So you want to cover it adequately with oil, and it generally takes about 4 to 5 ml, sometimes maybe like 5.5 ml, depending on the size of the dish. That much oil you would want to keep. Now, the next step is to basically create the VD droplets. So what I do here is you have to create a 1:1 dilution of cryoprotectants with hippies and mops. So I'm taking 10 microliters of hippies. I put 10 microliters of glycerol in the same dish, mix it well, and then you would only want to load 1 microliter or 0.8 to 1 microliter on the device as such. You don't really need to flatten the droplets too much because a rounder droplet is more stable, but that's what you need. So what I've done right now is I've mixed the cryoprotectants with hippies, and I will just take a stripper pipette, and I will, under the microscope, I'll just take 1 microliter and load all 3 droplets with 1 microliter each. That's pretty much how you would want to prepare the device. So if you can look closely, just 3 droplets. And once this is done, again, like I mentioned, you don't need to flatten it too much. So you can just lift it and insert it into the dish as such. So this is how the dish preparation would look like. Now, what we generally do is that we prepare semen samples first, and then in these hippies droplets, I would then load the semen sample. But what you can also do is that you directly make the droplets out of the washed semen sample. Only problem that can happen is that sometimes there's a lot of debris in the washed semen sample because it's a simple wash that you're doing. So you might need to dilute it a little bit in order to get a clearer sample. I generally wash and then load the sample 1 microliter each, or 1.5 to 2 microliters each in each droplet, and that's pretty much it. All right. Now, once you've done this, you straight away move to your micro manipulator, and all you need to do is identify and find sperms. Now, this is a case where, again, not many motile sperms were present. So just look for sperms, try and find them. If you find them quickly, only a suggestion or a tip that has been recommended here is that you basically would want to, as soon as you place 1 sperm into the cryoprotectant droplet, you would want to finish the whole process in about 8 minutes. So you don't want more than 8 minutes of exposure as far as this procedure is concerned. What you can do here is that you can pick up all the sperms, put them in the wash droplet, and then pick up all of them together and put it into the cryoprotectant droplet, so that you don't increase the exposure time. That's pretty much it. So we picked up a few sperms, and what we'll do is that we will move the dish to the cryoprotectant droplet. Now, what I generally do is that I will leave the sperms or deposit the sperms towards one periphery. One of my embryologists or junior embryologists would note down where I've deposited the sperms, how many sperms I've put in each droplet. So you can see that that's the periphery of the droplet. So we will just bring the needle close to the periphery and then just deposit all of these sperms here. You can see that there are about 7-8 sperms which we found here, which are deposited. That's it. That's how simple the procedure is. Now, once this is done, you would then lift the device out of the dish, and all you need to do is to place it in a vial and then just dip it in liquid nitrogen. That's it. So generally we identify, we use a cryo vial, and you can use barcodes if you're using that in your center, or you can also label it as per your protocol. You open the device, just take the device out. You don't really need to take out all of the oil from the device. There was a question on this, I think Harsh was trying to answer. So you don't really need to take out all of the oil from the device, because that also acts like a buffer and keeps the droplets stable especially when you're putting the device on the cryo vial. So all the shaking can dislodge the droplets. So a little bit of oil is okay, and it also is like added protection. And then you just dip it into your liquid nitrogen, or you can also dip it directly into the cryo can. Now, this was the freezing part. Now let's come to the warming. So what you need to do is that once you're warming, you take out the vial, allow it to settle a little bit, maybe like 30 seconds to a minute. And all you need to do right now is to just notice that the oil that's covering the dish has liquefied completely. That's pretty much it. Okay, so this video is a little sped up, so don't really worry about the timelines. But about 30 seconds to a minute, the oil should basically liquefy, and all you need to do is then just place the device into another dish. Now, this dish can be your ICSI dish, so you can make it as an ICSI dish with your droplets on one side, and the device can be on the other side, or you can use these special dishes which are there for Sperm VD. All right. So once this is done, you just immediately dip this device into the dish. And I mean, you don't have to wait too long, because if the droplets are liquefied, then you would be able to find sperms in this device as well. So pick it up. Don't wait for too long a duration. Go to your micromanipulator. Again, I would generally start from the location that I dropped the sperms at. But because they were motile, so they can swim all over the place. So you can start with a low magnification. And if you can visualize on a lower magnification, that's the best scenario. But if you can't, switch to maybe 20x and you'll be able to find sperms. And like it was mentioned in the previous talks, the recovery rate is decent. I would not say it's 90%. I would say it's anywhere between 60 to 80%. And yeah, it's a great device for freezing rare spermatozoas. So we are just searching. I also look at the periphery, and let me see. I can see one right there. And I mean, you'll be able to see these sperms swimming around. Just pick them up and use them for your ICSI. So that is basically how you would use Sperm VD. And I think everything else, the indications, everything has been covered. This is just a video demonstration of how you use the device. So with this, thank you. If you have any questions, we will take them up maybe later.
Thank you so much, Keshav. It was a nice demonstration, and I think I am also impressed with this video. You have showed that last survival rate. I was always skeptical. I don't know how I will get the survival rate or not. Always it was in my mind. Like now I can see that survival is very good. I can use that now.
Yeah.
Thank you. Yeah. So Rahul,
What they mentioned, sir, if I may interrupt you.
Yeah, please.
So even if the motility is not great, yes, what the people who've made Sperm VD in their protocol, it's mentioned that you can still use other things to induce motility, like theophylline can be used to induce motility. You could also do like a horse test on the same sperm, because they are expecting 90% survival with this device. When I do it, I'm expecting 60 to 80% of the sperms to be motile. And I mean, that is pretty much sufficient when we're doing ICSI.
Rahul, can we move to next video?
Can I ask a question?
Yeah, please, sir.
Sure, sir.
So maybe if we are searching in a very difficult case, and we need to search maybe for half an hour or even longer.
So this is before loading?
Yes. So can we search and pool all the sperms, possible
yes,
sperms in
yes,
a droplet with cryo protected itself?
No. So what generally is mentioned is that you pool all of the sperms in a sperm wash media or hippies, and then ultimately once you've pooled everything, you're happy with the number of sperms that you're cryopreserving, pick all of them up, load it onto the device. The only thing that they've mentioned is that as soon as you load it onto the device, the exposure should not be more than 8 minutes. That's it. So pooling can be done. I mean, all of these things can be done. They've also mentioned that you can do it in PVP, but I generally don't prefer it. what they've mentioned is that if you loaded it into PVP and then you're picking from PVP and putting it into the cryoprotectant, the ultimate thaw, post-thaw motility might be a little lesser, but it's still doable. So if you have more numbers, if you want more control, you can also start from PVP.
Yeah, the only thing is the concern is because in your mops or hippies, the spermatozoa tend to become little brittle, and sometimes it's difficult to handle those spermatozoa. So for the
So the thing is that we have to do it as soon as we load the sample into the device. We have to start immediately so that we finish the process quickly. The longer you wait, the tougher it becomes.
Yes, Sandeep.
So Keshav, yeah, it was wonderful. The thing is, maybe for the juniors, say you showed wonderfully how to phrase the motile spermatozoa with VD. But can you share your experience with immotile spermatozoa with VD, and how is it? What are the limitations with that?
I've only done one case with the immotile spermatozoa, and I mean that was a case where even after theophylline, even in a pre-wash sample, there was no motility, but the sperms were viable. So we froze that sample. We used those sperms for ICSI. I had embryos, but they arrested at 8 cell. That's the only experience that I have. In all other cases, let's say you're doing testicular sperm aspiration and you have immotile sperms, I would recommend that you allow the sample to wait for a little longer so that motility is induced, and then freeze the motile sperms from that sample.
Okay, thank you.
Also, please share your screen.
I'll share the screen. Just a second. Is it visible?
Yes, sir.
Yes.
Freeze semen routinely.
Audible?
Yes, sir, it's visible.
Yes, yes.
Indications and principle of the semen freezing. So spermatozoa were the first mammalian cells to be cryopreserved successfully in 1949 by Paul J., a Swedish scientist. He could make this discovery very serendipitously, and his co-workers were working on the cryoprotective effect of glycerol. Till then, so many more advancements have taken place.
Rahul says the video is frozen somehow.
Just a second.
The audio is clear, but the video is frozen. Sir.
Yeah. I think this video file may be corrupted.
So should I try?
Yeah, you can try.
Yeah, just so stop sharing. I'll try this time.
Yes.
So is the screen visible?
Yes, visible.
Sound is not there.
But there is no volume, Nidhi.
There is some problem with this.
Nidhi, you can do one thing. Stop sharing the screen and share the screen only with the video. Or sir, we can have Dr. Hetal here. He can
just give me a second, sir. I'll just do it.
Principle of the semen freezing.
Yes, ma'am. Yes.
So spermatozoa were the first mammalian cells to be cryopreserved successfully in 1949 by Paul J., a Swedish scientist. He could make this discovery very serendipitously, and his co-workers were working on the cryoprotective effect of glycerol. Till then, so many more advancements have taken place. cryopreservation of spermatozoa is done and stored under liquid nitrogen at -196 degrees centigrade, which will be useful for future to achieve the parenthood. The people who faces the challenge of their fertility, which is impacted either by chemotherapy or radiation therapy. Certain people have geographical challenges, they have traveling plans and all. Availability of the sperm on the day of the therapeutic procedure also is a question mark certain times, and certain professional commitments may alter the gametogenesis. Those should exercise the option of semen collection for cryopreservation. The other indications like backup of therapeutic usage, fertility preservation, R&D, donation of spermatozoa also is indicated for the sperm cryopreservation. Testicular spermatozoa after mesapisa, which will avoid repeated biopsies or aspirations, and male gamete freezing is largely recommended to preserve fertility who are exposed to the potentially toxic agents which may interfere with gametogenesis. Of course, many a times pre-vasectomy cryopreservation of the spermatozoa is also considered for future usage. And let's have a look at how and what happens during the cryopreservation process. This is a slow freezing method, and in this slow freezing method at certain temperature like -4 or -5 degrees centigrade, pure crystalline water is formed in the ice masses, and these growing ice masses, we can say unfrozen fraction is left where the sperm cells and all the solutes are confined. Now the concentration of all solutes like sugar, salts and cryoprotectant increases while the volume of the unfrozen fraction decreases. Now increase in osmotic strength causes influx of the water from the cells. Now slow cooling is needed in order to allow sufficient efflux of water to minimize the chance of intracellular ice formation. As cooling progresses, the viscosity of the unfrozen fraction ultimately becomes too high for any further crystallization, and this is how the remaining unfrozen fraction turns into an amorphous solid that contains no ice crystals, hence minimal chilling injury will happen to the cells. Now cryopreservation is a very slow freezing method for the spermatozoa. The cryopreservation can be carried out in either 0.5 cc straws or in 2 milliliter cryo vials. The media which is used widely, either egg yolk trace buffer or egg yolk free buffer media being used. Vials or straws must be labeled properly with patient's name, either donor's ID or clinical history number, date of freezing, storage location, and if it is for fertility preservation, we can mention it is for that. Vapor freezing and programmable freezer can also be used for the cryopreservation of the semen. Now we will have a look on how this cryopreservation process can be carried out by a video demonstration. Once the semen sample is collected and required documentation like consents and undertakings are done, the routine semen analysis is carried out following complete liquefaction, which is ensured by drop free fall, and macular chamber can be used for the sperm count and motility and morphology can be carried out by either wet smear or maybe by staining protocol. And this routine semen analysis can be helpful to control the total motile sperm count per vial, which can be at least 50 million motile spermatozoa in 0.5 milliliter of the volume of being frozen in a vial or a straw. This will avoid the overcrowding by dilution against the cryoprotective media. So here we are demonstrating the semen freezing by basic wash method. Basic wash, as everybody knows, is carried out by simple wash, centrifugation and pellet formation, where the semen sample is mixed with the culture media and semen sample is transferred into the sterile tube where it is homogenized properly before the centrifugation. And the centrifugation is carried out at 600 G force for 10 minutes for the pellet formation. Now, here one important thing which I would like to share with you is semen freezing can also be carried out with prepared semen either by swim up or density gradient method. And the density gradient method or swim up method, prepared sample will yield more number of motile sperm and immotile fraction will be significantly reduced, and that is how one can achieve better post-thaw sperm quantity and quality. Here the supernatant of the pellet formation is removed and pellet is resuspended, and cryoprotectant media is being added drop by drop very gently and being mixed. This should be done over a longer period of at least 1 to 5 minutes so that this hyperosmotic shock from the cryopreservation media can be avoided or minimized, because you know the cryopreservation media are having the osmolality of around more than 800 milliosmol per kg. Now this mixed cryopreservation media mixed with sample will be loaded into the straw and the vial, and this vial and the straw should be properly labeled with clinical history number, patient's ID or donor ID and all. Here you can see this straw is loaded and 480 microliter in a 0.5 cc straw is being loaded. You can see the open end of the straw. There is a blank space is kept. This space keeping is very important before we seal the straw, because if this space is not left there, then maybe straw will burst because of the expansion of the frozen material, and it is very important. These loaded vial and the straws are incubated for slow thermal equilibrium at plus 4 degrees centigrade in the refrigerator for at least 15 to 30 minutes. And then here you can see the setup of the slow freezing, vapor freezing. In styrofoam box, you can see the red lining where till that level liquid nitrogen has to be maintained, and vapor temperature will be around minus 100 degrees centigrade. The straws and the vials will be kept at the height of 6 to 10 centimeters in the vapor phase, and this at this vapor phase the temperature is being maintained at around minus 100 degrees centigrade temperature, and at least for 30 minutes this vial and straws will be exposed to the vapor. Timer can be used for this and to ensure the proper freezing. After 30 minutes, the liquid, the straws and the vial will be plunged into the liquid nitrogen, and after that they will be transferred into their final storage location in the cryocan that is pre-decided before the start of the freezing. Now we have taken out the pre-cooled vial holder, and this vial is being kept into this pre-cooled vial holder, and it is tightly kept there and placed back into the canister of the cryocan can. And here this is the end of the vial freezing, and now the straw will be transferred into the pre-cooled goblets having isotubes of different colors, and as decided to their location, the straw is being transferred and it is being placed back to the its location into that canister. The goblets are 2 goblets can be stored here in one canister, and roughly 500 and more than 500 straws can be kept. The programmable freezers are also available for the cryopreservation procedure. This is the programmable freezer. At this point, liquid nitrogen must be maintained throughout the freezing. So this is just a glimpse given to you for how programmable freezer can be used. Different programs are centered there for embryo, oocyte, and sperm freezing. Thank you very much.
Thank you, Dr. Hetal. I think we can. Hello. So if there is any question, we can take the questions.
I have one question for Dr. Prasad. Dr. Prasad, yes, you have nicely demonstrated us with the mesh method of crushing the seminiferous tubule. Do you think this is 100% means it can mash up or it can produce the granules, means it can mash the tubules in a very specific manner? Or have you used some other methods also to mesh the tissue?
The size of the, able to hear me?
Yeah.
The size of the pores is not such as fine where the passage of the sperm can damage. They're very, I can say this, open up meshes. So I never find any damage to the sperms or anything. And for the past 20 years, I'm using the same procedure, which saves really a time.
And do you get enough sperm in that for your procedure?
Pardon?
Do you get enough sperms?
Yes, sir. Enough sperms.
And what about the remaining part of
the number of sperms? It all depends upon the quantitatively what is present in the tissue. It is not relevant to the number of sperms towards this mesh or procedure.
Do you preserve that remaining part of tissue also?
Pardon, sir?
Because you told in your video that after completing the procedure, you freeze the sperms.
Yes.
Yeah. So what about the remaining part of tissue? Don't you think you have to preserve that also, or you are left that tissue, discard the tissue?
No. So total tissue, we'll use it for the squeezing and then separate at the same time, and then whatever the medium that is collected after the wash will be taken into the consideration for freezing or examination. Well, total tissue will be using it, whether it's a TISA or TC.
I'm also having a very odd question to ask.
Yeah, please,
every case you use a new coffee filter, and then how do you sterilize it, sir?
No, see, you can use the steam sterilization. That's fine. Or if you want, you can send it for an ETO sterilization, or you get it outside. It's available. Things. Or simple stainless steel mosquito mesh. A piece is good enough.
Okay, sir.
No need to be such a stainer or anything, but a simple stainless steel piece is good enough.
Can I ask one question?
Yeah.
Like you found any common difficulty in these procedures, which is not there in your routine ways of teasing the sperm out? Any common difficulty which you found in these procedures?
No, I didn't find any difficulty in freezing the sperm. But the only thing is, I find that this is a simple way to isolating the sperms from the tissue. That's all. But once you process it, whatever the sample contains the sperms, and processing the freezing or anything, it doesn't make any difference.
Tissue getting stuck to the pestle or something like that?
No.
So then crushing or teasing, have you done those methods also? Or do you think that this is superior according to your experience, sir?
See, I don't say that I'm superior or anything. I find this is the simple way. That's all. See, whatever the way that the intention is to squeeze it, the seminiferous tubules. That's only the intention. Whether you do whatever the way, it should be simple. And by this way, the time is minimized. And moreover, the exposure time, you are making it very less.
Can I ask one question to Keshav?
Yeah, go ahead.
Keshav, in the slides, what you presented and what you told, I heard the survival rate as 90%. You said. Did I hear it correct? Like survival. You said recovery of 60 to 80%.
Yeah.
And survival of 90%.
So sperm recovery from my personal experience is 60 to 80. Yeah. In the previous presentation, I also heard it's 90%. I have not.
Your literature says so.
I have not seen 90%. I would say it's 60 to 80. Okay. What I have seen is that this 60 to 80 is the motility that I get after thaw. But I have never tested these sperms with horse. I've not tested them with vitality staining, etc. So I really can't comment on the exact survival. But motile sperm retrieval is around 60 to 80.
Thank you. And thank you to Prasad sir.
Even I've read on paper which says that they used a specialized solution, vitrification solution with VD, and they're claiming 96% survival rate. So there are papers, but personal experience, again, it varies, right? So yeah. Probably.
Prasad sir, you can ask your question, sir.
Yeah, there's one debate was going, how many wash should be given for a tar sample. See, I made by studying with a single wash and double wash, and I found the double wash is the best way. And if the sample is used for an XC procedure, it's better to give a third wash. This for the juniors who are learning is an information for them. The more the number of washes, it makes the things easy.
Sir, any particular logic for giving a third wash per case? Any particular logic behind it, sir?
It's not a logic. You see, even the traces of cryoprotectant can block the XC needle if you are using the sample for an XC procedures. That's why the more number of washes that you give, the traces also will go off. That's only the intention. And even for if you are using for a sample for an IUI, it's better that you are taking out the cryoprotected whatever is in the possible extent.
Third wash means how much time you want to give that wash?
10 minutes. See, 10
minutes every time.
Pardon, sir?
10 minutes every wash.
Yes, sir. And
see, you are centrifuging 30 minutes.
No, listen to me, sir. See, it all depends upon the count also. So Sometimes very low count, it needs more time. Otherwise, 5 minutes also is good enough. It's a good sample.
I don't know at the end what you will get, because the motility is already compromised in such sample. So I don't know how much survival rate you will get after that doing this 3 washes. Little bit, I don't know. But Keshav, do you have any experience like that?
What I have seen, if the sample is good count, you can minimize the time. If it is very low count, maybe giving a benefit of things to come down, whatever the low count.
I've never done more than one wash.
Yeah, no.
Yeah, see, it's all the what we call it, your practice.
In case of infection, definitely I will go for 2 wash, like not more than 2 minutes wash. Not like that 10 or 10 minute wash. I don't know. Sanket, do you have any idea for that?
Yes, I wash only for 5 to 6 minutes.
Yeah.
Regularly, just to make sure that remove the cryoprotectants and whatever the extra things which is not needed for the insemination process.
So do you also wash your frozen samples, like sir said before doing IUI?
Yes,
do you recommend?
I for IUI also I wash it twice.
The other seniors, sir, Ved sir, Akash sir,
Nidhi, whole debate was going on in the beginning of the.
I saw that, sir. That's a wonderful debate.
Dr. Hital, are you there? Dr. Hital, are you there?
I can say that it's an individual personal experience. Whatever that it's only it's not mandatory or anything.
I think Chandan had a point on that, sir. I think Chandan had a very good point on that. Maybe nothing offensive to companies who are providing it, but they say just to make the pacify the clinician's job, they say that directly you can use it. Once you thaw, allow it for some time and you can use it, because that is very pacifying for them instead of going for preparation. So, but if embryology is there in the lab, then definitely you have to wash it, sir.
Yes. I think the place where I usually give a second wash is once you give a first wash, it's 1 wash for me as well, around 5 minutes time. Yeah. And when you add it to the PVP, sometimes you see coagulation. Probably it's some carryover of your cryo protectant over there, or when you have frozen a raw semen sample, probably the proteins or they couldn't have been washed off clearly. So in these cases, I've seen that when you give a second wash and take out the supernatant properly, and many of the times that coagulation disappears and the motility will be better in the PVP.
Right. Nikhil, do you want to comment on this?
We are using 1200 RPM post thaw washing just for 4 minutes. And for frozen IUI is also, with my own experience, I can say I have performed.
Your voice is not.
Is it okay now?
Yeah.
So with 1200 RPM wash with 4 minutes post thaw, we have means for IUI with patient's semen, out of 6, 3 pregnancies have been established successfully. And so, I mean, only 1 wash, milder wash is more than enough. That's what my experience is with this.
Any other questions?
I think there are no more questions for the day now.
Dr. Shukla ji here?
No, Shukla sir is not here.
So now we can close.
You can proceed with the vote of thanks, sir.
Yeah. So thank you everyone. Thank you so much for joining us. And thanks to our all faculty, our convener, co-convener, founders, co-founders, founders anyways, co-founders. So, and thanks to everyone, all the delegates, and thanks to Shield Pharma for supporting us. And this is the one announcement. We are again coming for third virtual embark on 12th and 13th November, and the theme is IVF consensus to adapt or to perish. and there will be many experts from national and international, around
I will
70
just check with the message her
experts will be
message
there.
that I'm done with. So if something is there, we will.
So with this, I invite all of you, and that registration will be free. And thanks to everyone. Thank you so much. Thank you. Thank you for joining us. Thank you.
Thank you, sir.
Thank you.
Thank you to all the speakers.
Thank you, everyone. Are we offline now?
Nine.